We are live online. We're getting ready for our radio broadcast that we do on a weekly basis on KDOW in the San Francisco Bay Area. That is 1220 a.m.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the Heart of Innovation, where we explore groundbreaking approaches that are changing lives for patients with vascular and cardiovascular disease. I'm your host, Kym McNicholas, and on today's episode, we are diving into an exciting advancement that I think could be a game changer for so many. It's a new minimally invasive approach to treat osteoarthritis, particularly in the knee. And I think it's especially important for people with poor circulation in their legs, known as peripheral artery disease, or PAD, which is more prevalent and deadlier than most cancers combined. Now, for these patients, walking is literally medicine. It's how they build natural bypasses around those blockages in their leg arteries. But here's the cruel irony. Many of these PAD patients develop debilitating knee arthritis that just stops them from the very walking that they need to do to save their legs. And because they often have complicating factors like diabetes or chronic kidney disease, they're frequently told they are not candidates for traditional knee replacement. The result? Well, too many patients are left in an impossible situation, walk through unbearable pain until they can't walk at all, and then face amputation when their circulation deteriorates. But today, we are exploring a better option, a limb-saving innovation called Genicular Arterial Embolization, or GAE. And joining us to explain this breakthrough is a pioneer for GAE, Dr. Osman Ahmed. We call him Dr. Oz. And a leader in the field, Dr. Sid Rao. And I am also delighted to have a very special guest who's also in the field, a guest co-host for Dr. Phillips, Dr. Misha Ginsberg from South Bend, Indiana. He is here with us today as Dr. John Phillips has the day off to go save those piggies, as he likes to say. So this is kind of medical innovation that we're going to be talking about that just truly embodies our show's mission, finding new paths forward when those conventional options fall short. So what do you think, Dr. Ginsberg? Time to get things started. Welcome.
Thank you. Great introduction. I think it's a really interesting topic, obviously, this high prevalence and incidence. And certainly, we live at a time when this particular field is exploding. So I'm actually very happy to have both Sid and us here for us on our show, both experts in their fields and some of the pioneers in genicular arterial embolization. I personally know us. I've kind of been inspired into the field of GAE specifically by him and his experience. So maybe if both of you guys and Sid, feel free to start. How did you get yourself introduced into this field? What inspired you to kind of pursue GAE as one of the procedures you perform for your patients in your practice?
And we got to get him to unmute.
Sid, unmute.
Good. Hey, guys. Hey, Kym, thank you very much for the opportunity. Misha, thank you very much. John, in absentia, thank you for allowing me to spend a Saturday afternoon with you guys. So I guess I'll start off. I'm about 16 years out of fellowship now, and I got into the peripheral arterial world more than a decade ago, and I've done more than 3,500 peripheral interventions now in my lifetime. But as Kym very adroitly said, it's sometimes not enough if you just are able to take care of the circulation. What we know from published data is it doesn't matter why you can't walk, whether it's because of calf claudication or a wound on the foot, or whether your knees don't allow you to, you have a 50% higher chance of dying from cardiovascular disease and cancer if you don't walk. So, somewhere along the way, when pioneers, and I give kudos to the interventional radiologists. I'm in awe of them. I mean, they chose to study this in an extraordinarily organized way, starting with Dr. Akun at the top, and we have our very own Dr. Ahmed here, who has been a pioneer in the field. And when you look at how the quality of data that they have repeatedly produced over the last 15 years, it's just unbelievable. They have created a field that helps patients, and this field has blossomed so beautifully, so quickly, to help all these patients that now can potentially walk, right? So as somebody who sees PAD patients who cannot walk, that's kind of how I saw it. I saw it as a moral imperative to do everything in my power in the OBL to try to see why I can't make them walk, So that's kind of how I got into it. I started doing these about 2.5 years ago, and we've already done more than 700 musculoskeletal embolizations in our OBL. I have done more than 700 now. And and again, we are all involved in this field, and I'm kind of old now, so I don't get into politics a whole lot. But what I wanted to do is kind of contribute to the body of literature in my own way and say, hey, look, I'm doing this correctly. I'm having a third party police my results. And that's why I signed up for an IRB. We pay them every year, and they kind of monitor our results. And, we look at our outcomes. So it's been extraordinarily heartening for me to see my PAD patients actually walk now.
Yeah.
Because their knees don't hurt. So that's a long answer to your short question, Misha, but that's how I got into the field. I view it as a moral imperative for anybody who's playing in the femoropopliteal and tibial space to do everything to enhance their skills to help their patients walk.
Yeah, and when there's talking about the popliteal it's the knee artery. So just to make it simple for everybody, we're talking a lot about knees. You might hear a little bit of clinical terminology. We'll try to break it down for you as much as possible. We're gonna put that in the hands of my co-host, Dr. Ginsberg, to jump in on all of the clinical speak and help break it down for everybody. But
you got it,
I
Kym.
do in the 1 minute before we have to go to break, I'm not going to give you much time, Dr. Ahmed, but in short, we'll expand later since you're a pioneer here. Just give us the quick Cliff Notes version of what is genicular arterial embolization.
As if you're explaining it to my 10-year-old kid.
Yes.
No problem. Thank you all again for having me on. So genicular artery embolization is a very, very fancy way to say that we are treating or targeting the inflammation associated, or what we believe is causing the pain associated with arthritis. And the way we do that is by taking a very, very small catheter, putting it into the artery, and finding where those areas of inflammation are, which is basically manifesting as abnormal blood flow, and basically blocking that blood flow.
That's fantastic. We're going to hear more from Dr. Ahmed, Dr. Rao, and of course, my guest co-host, Dr. Ginsberg. We also have joining us later on in the show, Dr. Nick Patel from Murrieta, California. He's also an IR working in the space. So you don't want to miss a thing. We got more to come right here on the Heart of Innovation on KDOW. Don't go away.
Good job.
Nice.
Go team. This is fun. We got to do this again. Okay, so Chris D is going to literally kick off the show with, you'll hear him coming back. There's the Heart of Innovation with Kym McNicholas and Dr. John Phillips, but then you'll hear Dr. John Phillips, spectacular vascular moment of inspiration. Literally, you're going to jump in on that, Dr. Ginsberg. Hey, Dr. Misha Ginsberg here from South Bend, Indiana. Dr. John's off today. I have the moment of inspiration and share your quote.
I'm sharing my quote. You got it.
And then I will respond to your quote. And it might be fun at this point, Dr. Rao and Dr. Ahmed, it's fair game. You don't have to wait for anyone. You can jump in and just have a good time. If you want to comment on the quote, if you want to comment on my comment, if you want to continue the conversation wherever we go from here.
Okay.
Just remind me the timing of me jumping into that. I want to go ahead.
So it'll be, you'll hear Dr. John Phillips, spectacular vascular moment of inspiration. As soon as you hear the inspiration,
you got it.
It only goes at doobly-doo. You can jump in.
And the next segment is 9 minutes?
9 minutes.
Okay. Sounds good.
I think Josh is so funny. He's like, I think Dr. Ginsburg's having the most fun.
For sure he is.
Man, letting him have control.
That's true. That's true.
I mean, we got to make it a little bit controversial. So I think that, the topic itself.
20 KDOW.
Here we go.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Dr. John Phillips, spectacular vascular moment of inspiration.
So this is a time I have to provide a quote, an inspirational quote. And for me,
love it.
Pessimists and optimists both contribute to society. The optimist invents the airplane, and that's us for you. And then the pessimist invents the parachute. So we gotta balance those things and coexist.
Okay, I like that. But let me challenge you just a little bit. So I do appreciate the quote, but in medicine, crucial difference, okay? Just bear with me here. The pessimistic doctor who tells a PAD patient, I'm going to flip it. The pessimistic doctor who tells a PAD patient with knee arthritis, okay, sorry, you're not a surgical candidate. Walk as much as you can until we need to amputate. Well, they're not really creating a safety measure. They're actually, in my opinion, abandoning innovation altogether when patients need it most. Now, the optimistic doctor who says, let's find a minimally invasive approach to treat your knee, Dr. Oz, so you can actually walk and save your legs, isn't just inventing the airplane. They're actually creating a brand new path forward, but the conventional route is blocked. And so in vascular care, I think we need fewer parachute packers and more pilots like Dr. Oz and, of course, Dr. Sid Rao, willing to chart new courses through medical challenges. Because unlike falling from a plane, I think giving up on a patient's mobility is not an acceptable backup plan. It is the very outcome we are fighting to prevent. What do you think?
I'm just happy Misha didn't look at me when he was saying parachute.
I was waiting for that.
No, but this is great, Kym. Spreading awareness about the fact that there is a treatment option for these patients who suffer endlessly for 10, 12, 13 years before they get their knee eventually replaced is very important. And again, kudos to people like Dr. Ahmed and Dr. Kuno and Dr. Mark Little and Dr. Sapoval in France, and all these guys who have kind of contributed to the body of literature. But this is an extraordinarily new treatment. Again, not a silver bullet, but again, the field is in its infancy, right? The widespread adoption of this field, really, at least in the US, has been only in the last few years. Yeah. When coronary artery stenting came out, you didn't have the most spectacular results like today. But it was a promising new field, and there's every indication with every publication that comes out that this field is only going to grow and get better. What do you think, Osman?
Yes, Sid, I agree with everything you said, and I think Kym, in your analogy, or Misha's analogy of planes and parachutes, I think it's a little bit different. I think what it is actually is I use this analogy a lot with some of my partners. is you need, in medicine, you need kites and you also need strings, right? You need people to kind of say, okay, hold on. And I think, Sid, to your point, you sort of touched on this, which is this is a new, exciting field, and we all want to do it, or we all want to try to help our patients. We also, the string part of this, or the parachute part of this, I think is, well, let's generate the data. Let's do it, through registries. Let's make sure that we are really understanding what we're doing and how much we actually are helping. And so I think, you always need the people that are crazy enough to kind of go out there and do something without really any evidence. But then you also need the people that are saying, well, let's try to make sure that we're doing this the right way and that we really are helping our patients. And so, and I think both are very beneficial to medicine, and it just sort of picks certain personalities to do both.
That's a 100% perfectly balanced statement. Yeah.
And Sid, you're a very experienced, as you mentioned earlier, experienced operator in the world of PAD, and clearly, you've jumped from planes with a parachute. But there's a lot of inexperienced people who may go into the world of GAE, and we're talking about some of the controversies here when we're talking about PAD and GAE combined, right? And so I don't want anyone to jump without one. Okay. And so we want to really clarify to the people who are listening here, what that would be a contraindication for GAE in a PAD patient, because what we don't want is people jumping out of plane without a parachute.
Yeah.
Agreed. I think the biggest contraindication from a physician perspective is not to do it just because you think you can't do it, and I'm not exaggerating here. So there are a lot of people that think that because they can put a wire and catheter in the femoral popliteal segment, they can do this procedure. This is an extraordinarily nuanced procedure compared to putting a stent in the femoral popliteal segment. I have seen complications from inexperienced operators doing this, and I've gotten called by other vascular surgeons and things saying, "Hey, man, what is this?" So from a physician perspective, I think you really need to get trained. Do the right thing. I mean, it's not complicated. Do the right thing. Get trained. Pick a mentor. Dr. Ahmed is extraordinarily gracious guy. I'm sure you can pick his brain. You can ask Dr. Ginsburg. Take advice. That's number one as a physician. Number two, from a patient perspective, I think severe PAD or diffuse PAD is really a big contraindication for an experienced operator, Misha. I mean, I still do GAE on my patients that have some PAD. What you begin to notice is in people with smaller arteries, in people with diabetes, just like the kidney arteries are the first place where you get disease when you have aortic atherosclerosis. You start getting osteal disease, so disease in the starting portion, the beginning of these genicular arteries. So often it can be very difficult to treat those patients, and that same disease can also be in the later half of the artery, making this a very poor treatment choice in these kind of patients. So I don't think peripheral arterial disease is the absolute contraindication to doing a GAE like it was probably proposed about 3 or 4 years ago when people started doing it. Again, with just like with everything else, as the data accumulates, as operators get better and safer, I think you can do this. It is not an absolute contraindication. A lot of the fear about doing GA in PAD patients was, I think, from one paper that suggested that when you have a popliteal artery occlusion, there are these large collaterals into which if you embolize by mistake, you get non-target embolization, and then you end up having to deal with the embolic complications. So again, training, I think, is key. I don't think you should try to do anything with fear or with reckless abandon. I think there has to be a balance, that you have to be sort of nuanced. And I think as an operator, you have to seek help. What do you think, Osman?
Yeah, I agree with you 100%, Dr. Rao. I think my practice probably mirrors very similar to yours in terms of, yeah, we shy away from somebody who has severe PAD, but I think for better or worse, they seem to be mutually exclusive. It seems to be that the patients who have bad OA they don't have a bad PAD. So usually we don't run into that problem that much. And I agree with you similarly that, as we'll probably talk about, the field of embolization for GAE is changing. We're using safer embolics. So I think that risk profile is also changing a little bit as well. So I agree with you 100%.
And coming up right here on the Heart of Innovation, we're going to dive deeper into the procedure and find out who actually is a fit for it and how to talk to your doctor about it. So stay right with us right here on KDOW and the Heart of Innovation. Don't go away.
3 years ago. I think it'd be good to have a timer, So
yeah, it's amazing how you do that.
Yeah, we just have it. It's in, she's showing off now. Thanks, Josh.
Yeah.
No, it's so he just puts in there, and I wasn't sure how long that 1 minute had been up. I was a little concerned. So I just jumped right in. But I do want to start off this block. I want to go into, let's really dive into embolization. What is it? Like, what are we embolizing? When I get asked by my patients after I first started talking about GA a while ago, like, I can't afford to lose my arteries. I have enough problems with my arteries. What happens if you take that artery and I don't have problems now, but then I have problems later? I mean, this is how the patients actually think. Also, in terms of, just this procedure, like, what are we talking about in terms of the indication? Or is it bone on bone? Or what type of arthritis? I want you to go kind of into the diagnosis that people have and what the alternative is, which is doing the knee replacement surgery, and why someone would choose this over that. And if they choose this, are they just delaying the inevitable when it comes to knee replacement? And if they're younger, why not do it now versus later? Why do this now and just put off doing the knee replacement? So all those questions I think that we need to answer in 6 minutes or less. No, I'm just kidding. We have 6 minutes and 20 seconds in the next segment. And but in the next segment that follows is going to be, I think, about 8 or 9 minutes. So we'll get as much as we can here, and then we'll go into the 9-minute segment as well.
Very good.
And we have Dr. Patel came back. Just want to make sure everyone's muted.
Misha, which hospital system are you with?
Beacon.
I'm sorry?
Beacon.
Oh, Beacon. Okay.
Beacon, and work at Memorial Hospital. It's one of the largest hospital in South Bend.
Very nice. Very nice.
Misha, your billboards are everywhere here.
Billboards.
He's a local celebrity.
Really? Someone's going to have to take a picture for me so we can embarrass him.
100%.
I'm allowed to do. He can't get mad at me if I
30
post
seconds.
it up on LinkedIn, right?
That's true.
But I do think it's good to kind of ask the question about patient selection and how both Sid approaches that and us, and as well as a workup, so that kind of prepare yourself, guys, because I'm going to be asking you both in terms of patient selection, workup of your patients, and referring patterns as well. Okay.
You guys are in so much trouble.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. Dr. John Phillips is off saving some piggies, so Dr. Misha Ginsburg from South Bend, Indiana, has generously donated his time to be here on a very important topic, which is genicular arterial embolization. Whew, that was a mouthful. GAE, probably something you've never heard of before, probably hearing here for the first time. But so many people as we age have knee problems, knee arthritis, and we do not want to go through a big knee replacement, right, Dr. Ginsburg?
I agree. So ask a question for you. What's the biggest misconception of knee osteoarthritis?
Yeah, that's a great question. I think the biggest misconception probably is that you don't have many options available to you. You know, I think most people think I have arthritis, and really the only thing that can be done for it is a knee replacement. The reality is there are multiple therapies, including genicular arterial embolization, to potentially help or aid our patients with this disease.
So how are you deciding between doing knee replacement and going in the other direction? I mean, it just seems to be the thing to do. You get to a certain age, everyone goes in for this knee replacement, but the recovery from what I've seen is wretched. It's a lot of time to get back to where you should be.
Totally.
Kym, I'm just,
Oh, yeah.
go ahead, Oz.
I was going to say, no, it's a great question. I think there's basically two types of patients that you'll see, you know, if they come to you as a non-surgeon, which is patients who are either ineligible for surgery or they want to delay surgery or try to avoid it if they can. And as you mentioned, Kym, there's a lot of reasons to delay or avoid surgery, especially because of the downtime associated with it. A lot of patients, for economic reasons, for example, have to take care of other, you know, they're the, you know, sole providers in their home. They can't afford to be, down for 3 months. And so, so when you see those patients, they are really they're really out there looking for these options, and they're not being presented to them, in their entirety. So, we always try, very conservative, basic interventions first, such as steroid injections, hyaluronic acid. But then once those fail, along with physical therapy, and they all do fail eventually, we just know that that's the normal timeline of these therapies. Then we are left with very little options, historically, with very little options before we recommend a knee replacement, or where we go on to recommend a knee replacement. And that's where these therapies, minimally invasive therapies like genicular arterial embolization, I believe, have a very large role.
So walk us through the procedure and how long it typically lasts. How long can I delay, in your experience?
But I just wanna interject for a quick second here to make sure that the public understands that knee replacement is a gold standard, right?
Yes.
If you're a candidate for knee replacement, that's a definitive yes treatment that works, right? And as Zaz correctly sort of mentioned, this is not a procedure that competes with knee replacement by any form or fashion. This is a procedure for people who are not candidates or want to delay, but it's only if they actually want to delay. If they're at a point where they need a knee replacement and they're candidates and they chose to do that, this is the way to go. Okay, this is not a competing alternative. This is a minimally invasive option, either to bridge them to a knee replacement, okay, or offer them something because nothing else works, and they're not candidates for knee replacement. Sid, you want to kind of weigh in on that before we jump on Kym's next question?
Yeah, thank you for raising that point. So I'm going to push the envelope there a little bit. Again, Dr. Okuno prospectively followed a small cohort of patients where he treated them early with genicular artery embolization, and he noticed on MRI follow-up up to 2 years that the loss of cartilage and loss of the meniscus thickness was not even 1/10 of a millimeter out 2 years after he did genicular artery embolization on patients with mild to moderate but symptomatic osteoarthritis. So again, I think this is complementary therapy to the treatment. It's complementary therapy for patients with osteoarthritis. I don't think we know definitively whether it is going to replace knee surgery. I don't think it is going to, but it definitely adds a powerful tool in our armamentarium to treat these patients. For instance, if you look at knee replacement, there are at least 3 or 4 papers that I know of. I read these things pretty avidly, and they're all from the orthopedic surgery literature. 20% of patients after a knee replacement still have pain up to 1 year out. 20%. This is a procedure that takes about 3 months of rehab for you to get back to about 60 to 70% of normal, you know? So it's a pretty big surgery. And like Kym was saying, if you are the sole breadwinner for the family, if you're too old, if you're too young, I mean, you don't want a 35-year-old or a 40-year-old mother who's driving around her kids to school to get a knee replacement. In 10 years, in 10 to 12 years, they're going to probably need one more knee replacement, right? So I do think there is some promising evidence that this delays knee replacement, and therefore it's a great complement to existing modalities of treatment.
And coming up right here on the Heart of Innovation, we're going to have more with Dr. Ginsberg, Dr. Rao, and Dr. Ahmed. So stay with us. We're going to get more answers to our questions about GAE as a minimally invasive treatment for knee issues, knee arthritis, that pain in your knee that's keeping you from walking to your favorite tune.
Was that 6 minutes?
That was 6 minutes.
That was so fast.
Fast, runs fast.
I was afraid to say it. I was gonna walk into your favorite tune. So I'm curious. So Douglas has a question just here, just in the break. This is probably 8 or 9 minutes on this next one. He'll ask that question, but I do want to get into, so if someone is bone on bone, I mean, are we causing more damage by delaying a knee replacement? Like, I'm still wondering about the actual indications for this. And, kind of where do you draw the line? If someone goes in and they're like, oh, shoot, I am, like my dad with his hip. I mean, even if the embolization was available for the hip, I mean, he was really bone on bone. And I'd be fearing that, great, you took away the pain, the inflammation, but I'm still bone on bone. Am I causing more damage?
Yeah, I mean, once it's bone on bone, you have to realize, Kym. So osteoarthritis, everybody thinks that it's this very nice segregated loss of cartilage between the bones. The meniscus just wears out, and then the bone starts touching the bone. This is actually an extraordinarily pervasive illness in the knee joint. When you look at all these basic science studies, the meniscus is worn out, the cartilage is worn out, even the ligaments are worn out. So there is a point at which you have to replace the knee joint. So this is why GA is less effective when the disease is advanced rather than when it's in the early stage, mild to moderate stage, right?
Gotcha.
So it's like anything else. I mean, if it's a very advanced modality, you're going to need much more of an invasive therapy. So if you're in the earlier stages, then a minimally invasive therapy helps.
And Douglas is just asking about arthritis and PAD. Can one lead to another, possibly?
If you don't walk at all, yeah.
Yeah, if you don't walk at all, you end up with both, actually.
Yeah, you end up with a bad cardiovascular risk profile. So that's why I was saying, I think this is a moral imperative. If you have the skills, you're already in the FEMPOP territory, get a mentor, learn it properly, because how many coronary artery disease patients do we have? It's about 25 million, of which about half of them get treated with stents and bypass surgery. Conservatively, there are 67 million people living with arthritis in the US right now, half of which are knees, about half of which are, again, symptomatic. So the disease burden is enormous. It's about 10 times that of PID. Yeah.
Dr. Ginsberg, can you bring us back and ask Dr. Rao about just the pure numbers, how big of an issue this is?
Sure thing.
That's pretty cool information. And then whatever you guys, we have 7 minutes.
Yeah. I mean, I think Sid touched on it nicely that OA is linked to coronary artery disease, but it's also linked to mental health issues as well. Suicidal ideation, depression, because, if you think about it, this is the one disease that for quote unquote healthy people, as they get older, your knees break down, you lose your physical, loss of independence. And then that really has a mental and then as well as a cardiovascular, negative effect. And so it really, like you said, we always talk about how PAD is a very prevalent disease and there's more than enough for everybody. It's kind of the same with OA as well. Like there's just so much of the disease. We need everybody kind of really trying to, attack it.
Yeah. So we should also get into like the types of doctors that are doing it. It's kind of fun. Misha, you wanted to, cause some trouble. So that's a good topic to cause trouble on.
He's always looking to cause trouble.
I love it. He's gonna be my permanent co-host.
Oh, John got a demotion.
We'll keep John.
We love John.
I'll come in when he's needed.
Hey,
that's exactly.
It's
my
the one thing
guest co-host. I mean,
it's the one thing IR can take from cardiology. Finally.
Funny.
And Dr. Rao is fighting that. It's interesting because he just had Anita Dua in there, and she was raving. Like, what I love about Dr. Anita Dua is that, I mean, she's a surgeon at Mass General, and she's so open to all practices and loves knowledge. She loves pioneers. She loves innovation. And she's one of those amazing doctors that just
30 seconds
saves, innovation.
She was very insightful. I'll tell you, Kym, the kind of questions she asked during the course, I was like, wow, she's really into this stuff. So
yeah. Dr. Ginsburg, you're taking us back?
You got it.
Okay.
SRN.
AM 1220 KDOW.
And we are back. Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, guys. Thank you for coming again today. It's such a fascinating topic of genicular arterial embolization that affects so many. I know personally, some of my parents are affected by knee osteoarthritis, and
really,
oh yeah, and actually, to share a personal story here,
yeah,
Dr. Ahmed recently treated my dad for knee osteoarthritis. Definitely, yeah.
No way.
Great results. He walked with his dog the same day. So, Sid, tell us a little bit about the prevalence of an incidence of knee osteoarthritis, and maybe the patient population that's affected by it.
Yeah, I mean, it just hits close to home, doesn't it, Misha?
Yeah, 100%.
It does. Yeah. So this is a good question, right? Everybody needs to know this. So when you look at the CDC statistics, there's about 15 or so million people that receive stents, bypass surgery, some sort of heart procedures. And there's about 10 more million of these that are handled medically, about 25 to 26 million people. So with coronary artery disease living in the United States. If you look at the instance of stroke and cerebrovascular disease, about 7.5 million people get stents or carotid surgeries, and about 15 million or so are on medications combined. So none of all these diseases pale in comparison to osteoarthritis. The incidence of knee arthritis is conservatively about 33 to 34 million in the United States. If you put together other forms of arthritis, hand, shoulder arthritis, hip, the number is about 67 million or so. Again, very conservative numbers, 67 to 70 million people. So the disease prevalence is more than twice that of coronary artery disease and 5 to 10 times more than that of symptomatic peripheral arterial disease. So extraordinarily prevalent disease. So this needs to be kind of disseminated. These numbers are important for people to know.
And Dr. Ahmed, I mean, it's the arthritis. It's just not in your knees. I mean, we're talking about shoulders. We're talking about feet. I mean, there's so many paths to explore when it comes to doing this type of procedure. Then, I mean, even hips at some point could be something, because I know that when my dad was on deck for hip replacement, the months that he had to wait. Well, what if he could have something like this, maybe in the months waiting for having to get the full hip replacement? I mean, the pain he was in, the suffering, he could not have a good quality of life. So this could do so much for so many people in so many different ways.
Kym, you're absolutely right, and I think the numbers that Dr. Rao just provided are very sobering. You know, we're talking about just arthritis, right? And we're talking about 30 million patients with knee arthritis. But if we go back to what this procedure is predicated on, which is trying to target inflammation that's causing this disease, then we actually open up a whole other categories of diseases that we could potentially treat. So not just arthritis, but now we're also talking about musculoskeletal sports injuries. We're talking about patellar tendonitis, jumper's knee. We're talking about plantar fasciitis, Achilles tendonitis, frozen shoulder, hip bursitis. So there's a myriad of diseases if we can actually sort of validate or prove that treating inflammation as sort of the root cause of pain. Then we're really opening up a wide variety of diseases. There's actually even trials now going on to treat back pain, and so as sort of being caused by inflammation. So the possibilities, I think, are endless. And again, going back to kite and string, where we really need to hopefully try to get the data to sort of prove or validate this. But then we're talking about being able to treat, a whole lot more folks.
So the embolization, so you're talking, so it's inflammation that you're targeting, and it's these little vessels, these arteries, or is there one main artery in two certain areas of inflammation that you just embolize, you kind of cut off, you say, hey, stop feeding this area of inflammation, and suddenly the inflammation just goes away?
Yeah, you're exactly right. I mean, you explained it very well on a sort of on a simplistic level, which, so basically what happens with inflammation, this is actually to vascular specialists like Dr. Rao and myself and Dr. Ginsberg, inflammation is actually caused by abnormal blood vessel growth. So just think of like a tree, the branches of a tree, the leaves forming. There's just abnormal kind of blood vessels that are sort of forming off these normal blood vessels. So we go into the normal blood vessels and we search for these tiny little abnormal blood vessels, and we essentially block the blood flow to them. So patients very often ask, well, what about the normal arteries? We're not blocking blood flow to those normal arteries. It's just to the abnormal areas.
As we discussed before, I think the misconception is, not just in the public, but across the medical community, is that, you have this inflammatory and non-inflammatory arthritis, right? And so when we look at osteoarthritis, we think about it, Kym, as non-inflammatory, right? Which is a misnomer. It's incorrectly labeled, right? Because essentially there's quite a lot of inflammation. That's why people are on NSAIDs, right? Non-sort of steroidal anti-inflammatory medications. That's why they sometimes get injections with steroids into the joint, which really don't work as well. But there's some other things that work when they inject into the joints. But essentially, what is that targeting? It's targeting inflammation, right? So what is destroying the joint? It's inflammation. That vicious cycle, that closed loop cycle, the angiogenesis that Dr. Haas is kind of referring to, which is the formation of those new blood vessels. And that's what the GAE kind of puts a block on. So go ahead.
Coming up right here on the Heart of Innovation, we'll have final thoughts from Dr. Ginsberg, Dr. Rao, and Dr. Ahmed on genicular artery embolization. So stay with us right here on KDOW on the Heart of Innovation. Don't go away.
Final thoughts. Are you already tired of us, Kym?
I know.
That was fast.
We literally have 4 minutes in this last segment, but if you wanted, and I know Josh would love this if Josh is still here. There he is. We have not done an after show in a while. So if you guys want to continue with a few thoughts for a few minutes see his little sunglasses. He loves the after show. We have a couple people, we have Douglas and Heinz that may have a couple questions here. We allow a couple people into the live studio audience. But you'll have those, and then I'll get to each of your random questions as well that I have for you. But yeah, these are just kind of final thoughts. I usually try to let you guys do most of the talking, especially in this last segment, because there's just not that much time. So we want things that are tangible, actionable for patients. We have Heinz that wants to what is the test that you get to determine if this is right for you? What are the questions that you need to ask your doctor to determine if this is even an option? There are a lot of doctors that get annoyed. Oh, I heard about this GAE. I want this GAE, but whoa, a better approach is, hey, I learned about this GAE. I'm curious. I learned about certain indications. Am I a fit for this type of procedure? Or is it, if we deal with just sometimes the doctor doesn't offer it, so they say no. So it's good to offer, the idea to people to get second opinions, and they need to know what doctors to look for. And I don't know on some of the other websites, but I know that Society for Interventional Radiology really has a robust find a doctor system that shows, like, if you want fibroid embolization, if you and it goes down, pain control, it has the doctors that are doing it. But is there anything, because I don't know who does it in my area, I have no idea.
Well, I think the people doing it are at least doing a good job of advertising that they do it. I think
Okay.
if you simply go to Google and kind of type in genicular arterial embolization, I would imagine almost most markets. Sid, I'm curious what you think here, but that that the people that have been doing a fairly high volume of them will show up.
Yeah, yep, I think so too. Yeah, I mean, we do online marketing for sure, because PAD, some venous, and GA is all I do. In my OBL, like, I don't go to the hospital, I don't do cardiology at all now. So yeah, we definitely allocate some time and resources for marketing in different formats, digital or word of mouth, or I'm not as good looking as Misha, so I can't put my face on a billboard. But
Sorry. Yeah,
30 seconds.
But just to kind of a counterpoint to Sid, besides the good looks, it's also, I benefit from practices like Sid, who go and do digital marketing, because then those patients who find out through digital marketing about GAE as an option go to the primary care doctors, who then ask me if I do this procedure and start sending me patients.
there you go.
So, like,
There you go.
I
1220 KDOW.
I have more to expand on that, but that's
Welcome back to
I
the Heart of
essentially
Innovation.
I don't
For
need to
more
market
on
it.
today's topic, go to
Osman says you're welcome, Misha.
theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back. Dr. Phillips is off saving some piggies. We're rounding third, as he always says. I cut my guest co-host, Dr. Misha Ginsburg, off right as we were going to break. I wanted to let him finish his thought. And in this last segment, let everyone give their final thoughts, the tangible ways in which patients can explore getting this procedure, questions to ask their doctor, as well as the tests that they need to ensure that this is appropriate for them. Dr. Ginsburg.
Oh yeah. So we were talking about how people find out about these procedures right now, right? And what is the general sort of public knowledge of this being an option at all, right? Who offers this? And those are some of the challenges that patients face, is finding the right specialist and finding if they're the right candidates for this procedure. So Sid, you wanted to tell us about what's your referral pattern, and maybe who are the doctors who are sending you those patients? So is that direct to consumer marketing, and how people at all associate you with embolization, right? Because
yeah, I mean, you're an interventional cardiologist.
Yeah, that it's not exactly within, at least conventionally, within your sort of specialization.
Yeah. So the easy answer is all of the above, Misha. So when I started doing the first few cases, obviously I had one of my IR friends come and proctor me, and he signed off saying, "Hey man, you can do this. This is you got good hands." So I said, okay. And then I started looking for osteoarthritis in my own patients who were getting repeated rounds of injections and pain medications and physical therapy and braces. And I said, look, I think we can offer this. And when you get good outcomes, the outcomes kind of sell themselves. So I have like an interesting story to tell you. I had one of my PAD patients, PAD coronary artery disease patients, that came to see me just for his annual follow-up. Everything was stable, but he was hobbling in, and I said, "Hey, what happened to you?" So he said, "Oh, my knee hurts." And I said, "Maybe I can help." So did his GAE, and guess what? He was a trucker in this union of truckers about 60 miles north of us, and he went and told everybody. So now I can be sort of the de facto president of that truckers union because I've treated all the truckers there, and they all are back to working, right? So word of mouth really does spread quite a bit. But then in addition, like you said, talking to your referring physicians that used to send you patients for PAD and venous, and then disease, and then digital marketing, of course, is the sort of the new kid on the block that seems to work too. But I think the right answer is a combination of all of the above, is how I've reached out to patients.
And Dr. Ahmed, what are the tests that people can do to determine if this is an actual procedure that might be right for them?
I think the good answer, or sorry, the good thing about GAE is very few people are not candidates, especially if you've tried the very basic things that we try for arthritis, such as the steroid injections and physical therapy, and I actually require those to do a GAE. Yep. But I encourage, just like Dr. Rao said, we're out there, doing this, and we're putting our names out there. So just find somebody who has a lot of experience and sort of knows what they're doing.
And you can always go to the Global PAD Association's website at padhelp.org. Call our Leg Saver hotline at 1-833-PAD-LEGS, and we will help you to find a doctor who might be doing these procedures near you. We want to continue this conversation. So if you're on KDOW, go online, go to YouTube, youtube.com/the @ the way to my heart.
You've been listening
and let's
to
continue
The
this
Heart of
conversation.
Innovation with Emmy Award-winning journalist Kym McNicholas and interventional cardiologist.
Hi, everyone. Welcome to the after show for our June 28th episode, where we are talking about genicular arterial embolization, or GAE. We got my amazing co-host. For the day, we have Dr. Misha Ginsburg from South Bend, Indiana. And we have amazing guests. We have Sid Rao, Dr. Sid Rao, and Dr. Osman Ahmed. And I think we have Dr. Nick Patel, who might jump in for a few minutes. What have we, just let's give everybody the Cliff Notes version if they're just tuning in right now and they missed the entire first episode where we went into the basics. Don't all speak at once.
Yeah, I'll very quickly summarize.
Let's get to the pioneer.
For sure. So we went over the huge burden of disease with osteoarthritis. Dr. Rao really nicely outlined that there's about 30 million patients in the U.S. with knee OA, and about
each of them with two knees.
With two knees, right?
Good point.
So we'll go back to 60 million. And then we just talked about how essentially there's medical therapies, there's surgery. Surgery does work very well, but not many patients, or so there's a large number of patients who are ineligible for surgery or looking to delay it. Genicular arterial embolization is really an ideal treatment for that patient population, of which there are many, many, many patients. And then we went over some technique, as well as the need for more literature, more data, and education around the disease.
I'm curious.
That's a great synopsis.
Dr. We didn't get into how you became interested in this. You're a young guy and you are one of the pioneers in this space. Was there a certain aha moment for you, or has this always been an interest of yours?
It's a great question. I've been in academia for the last 10 years. I actually just left to sort of pursue a similar path to Dr. Rao in terms of having an outpatient center. But I've always been intrigued by new and emerging therapies, and I started doing GAE about 5 years ago roughly around the COVID time. And so that was kind of a period where I had a lot of time on my hands. I've always been very academic in terms of reading literature, again, similar to Dr. Rao, and sort of saw all the work that Dr. Acuna was doing. And then, very fortunate to sort of know some of the other pioneers like, Dr. Sid Rao, Dr. Acuna himself, Dr. Bagla, Dr. Golzarian, and with their mentorship, kind of really jumped into this, and again through the society as well as through research, started exploring this, and I think we talked about this earlier a little bit, which is the procedure works, or it seems to work very well, and so it was a fairly easy practice to build because of its success, as well as I always tell people this, and I think this is one of the things with IR that can, be relatively controversial is, a lot of the therapies we do, prostate embolization, for example, it competes with, urologic procedures, but I don't think GAE competes with anything. I think it truly addresses a treatment gap. There are patients who cannot have surgery or don't want surgery, and they're just left suffering. So that's what I really liked about it, was that I really thought it could help a group of people that otherwise didn't have an option.
And I love the fact that both you and Dr. Ginsburg were on previously earlier this year talking about prostate embolization. And that's another show. So for people who are watching, you might want to search our YouTube channel at youtube.com/@the way to my heart. And you don't want to miss that episode. That was fascinating as well. It seems to me that the trend is in embolization, and there's an organization where I'm really good friends with the founders, Rachel Basinger and Justin Lesh, and they're doubling down on marketing for it and really giving some of the folks that are doing this a great chance at getting this in front of the public, creating this groundswell through patient pro marketing. So this is a big deal. This is a real emerging trend that we're seeing, and we haven't even gotten this far into it, have we?
No question. And I think, and I apologize, Dr. I'll just say very quickly, I think at least our specialty has historically been so hospital-based, right? And I think now we're having a bunch of these, along with peripheral arterial disease, a lot of these embolization-focused procedures, they're actually much better suited for the outpatient space. And again, that's one of the driving factors for why I left the hospital, is these are therapies that I think we can actually sort of improve the access to through the outpatient model, because they're very friendly, like prostate embolization, like genicular arterial embolization, among multiple other embolization procedures like fibroids and hemorrhoids and things like that. And so, I totally agree with you. I think we're just at the beginning of this, and I think it's a really exciting time for that reason.
And I want to cause some trouble. So, it's interesting because interventional radiologists do so much, and yet you do not get much of the credit. You do hide in the back of the hospitals. But what people don't realize is that I think you're the only practice that can actually drive the boat all the way throughout the body. Am I correct?
Besides the heart.
That's really at the premise. What?
You don't touch the heart.
Oh, except the heart. Except the heart. That's Sid Rao's job. That's Dr. Rao's job, right?
Sid
was right. Interventional cardiology.
Quit the heart.
Yeah. So this is what I am. I'm an interventional angiologist. How about that?
Okay, there we go.
That's what I am.
Germany.
Sure.
I'm
in Germany.
Legs and arms guy. That's it. That's all I'm, a legs and arms guy. But I think to your point, Dr. Ahmed, I think it's important for patients now. I mean, with a clear moral tone, we can tell patients, hey, look, when you've been told that there's nothing else that can be done and you have to wait a few more years for your knee to get replaced, I think we can very clearly tell patients, no, there is an option. I mean, Kym, you kind of can relate to this. You always tell your patients, get a second opinion, get a second opinion. Even now, when I go and educate physicians in my area, right, they all think this is just a degenerative illness. I mean, there is a plethora of papers. Every time I read a paper, I put it in this folder that my NPs, my PAs, my vascular medicine guys, all the physicians that work for me, I make them read them, right? there's tons and tons of data that this is an inflammatory illness. So when the treatment, there is now a legitimate treatment, why not ask for a second opinion? Why suffer needlessly for years and years and years and let the damage go, unchecked? It's important to understand that this is a progressive illness. Everybody progresses, but at varying velocities, depending upon how many new abnormal blood vessels they have. So what I tell patients is, hey, I'm not going to block your blood vessels off. When you were born with a few blood vessels. I'm going to try to restore you to that state. I'm just going to get rid of the abnormal blood vessels and leave your normal blood vessels alone.
How do you spot them? How do you spot which ones are abnormal? I'm curious. So walk us through that process and paint the picture for those people. I mean, you go in, you're under, it's angiography, right?
Correct.
And
Correct.
You're under an X-ray. You pump in the contrast fluid, the dye, into the arteries so they light up under the X-ray. Take it from there.
Correct. So normally when we put our microcatheter in one of these genicular arteries and inject contrast dye, normally you see a nice branching pattern of a normal artery. But when you have synovial inflammation, which is the soft tissue surrounding the knee joint, you see this diffuse haze. You see this background darkness that you normally don't see. And that's all we are trying to get rid of. We are trying to get rid of only those abnormal blood vessels that are causing the background haze. And that's why I said this is a finesse procedure. It's not a, you don't run roughshod with these arteries. You have to be very careful. We inject literally 0.1 to 0.2 ml of fluid every time. Take one more picture. So it's a very careful, thought out procedure, Kym.
Yeah.
So we look for this abnormal blush, try to get rid of it, restore your arteries back to normal.
So what does it mean to actually embolize?
So we inject small particles that kind of preferentially find these small blood vessels. So I use a lot of what's called Primaxine, which is a semi-synthetic penicillin. So when you dilute it in contrast, when you reconstitute it with contrast dye, what it forms is these small 20 to 90 micron particles that preferentially find these abnormal blood vessels. So when we inject these particles, it kind of floats through the normal ones and then tries to find the abnormal blood vessels. That's basically what embolization is.
Dr. Ahmed, do you want to weigh in? I heard that there was a drug prior to this one. There have been a couple different ones.
Yeah, so the procedure was originally described using what's called imipenem-celastatin, and I think a very similar agent to what Dr. Rao is speaking to, which is actually an antibiotic, as mentioned. But when you mix it with contrast dye, it actually turns into like a crystal. And that crystal is what, when you inject it, can go and actually physically or mechanically block the blood vessel. And one of its sort of positive attributes is that it's a temporary agent. So it's not a permanent embolic, which makes this a much, much safer procedure and sort of mitigates or sort of avoids some of the more complications or some of the complications you can see with genicular embolization. So it's an embolic that's well suited for this procedure for that reason. But one question that patients ask then is, well, if it's a temporary embolic, well, how is that helping? Because if it just washes away, well, what we know, thanks to Dr. Akuno's work, is that these abnormal blood vessels, the ones that we're trying to take out, they're more sensitive to these crystals, meaning when you put them into those arteries, they actually can sort of die off with just with a temporary blockage, whereas the normal arteries, they're not affected by this temporary blockage. They'll sort of kind of get blood flow back, and so we really take advantage of that property to help us safely treat these patients.
Is there anything that you see? Do you want to say anything else on that? I'm just curious how you see this evolving. Is there anything during these procedures that you still see as in need of innovation, or do you think you've perfected it?
I think the one of the things that Sid kind of alluded to is that it does kind of require finesse in terms of the endpoint of embolization. And what I mean by that, and both Dr. Haas as well as Sid can weigh in is, when do you stop, right? Because especially for people who are not experienced with embolization, there's sometimes too much, and that's kind of the experience here and understanding. You're taking out this blush, you're taking out that something that lights up sometimes like a light bulb when you inject that dye, that contrast, that tells you where the inflammation is and kind of points you to the sites where most sigma, like my son would say, for sources of pain, obviously correlating it to the site of pain or where patients experiencing pain. And your job is to take away the blush, but maintain the blood flow through the parent blood vessel, the genicular artery, right? And so, the key is not to over-embolize. Okay, correct.
So how do you as a patient?
I just want to jump in here, Nick Patel.
Yes, please. Hi, Dr. Patel.
Hi, Kym. Hi, guys. Great conversation here. I know Oz is doing some research also on temporary agents, and I was just wondering, we were talking about PAD and osteoarthritis. Do you tend to use more temporary agents when you have PAD patients for OA compared to permanent agents? I mean, do you think it's a little more safer in these patients, compared to using permanent agents? Does that sway your decision making about which agent to use?
Yeah, so just
question.
The presence of PAD, that's a great question. I think so. It's really the angiographic blush that kind of determines what you're going to use. I mean, just the presence of PAD or not is not the only determining factor, at least in my practice. When the PAD does affect these distal portions or the end portions of the blood vessels, then your blush tends to be a little less profound. I probably will use a reversible or a temporary agent a lot more commonly. But if you have somebody, so for instance, there's nothing much you can do for patients, orthopedic surgeons, nothing much you can do once patients have persistent pain after knee replacement. The angiographic pattern in these patients is different. They tend to have humongous arteries, big arteries. In those kind of situations, you can certainly use permanent agents too. So a lot depends on what you see once you inject with the catheter, at least in my opinion. What do you think, Misha? What do you think, Oz?
Well, Oz would be the more of an expert, but I do use both resorbable sort of agents and particles. And due to the, as mentioned, safety profile, I kind of more transitioning more into things like Lipido. It's harder to use antibiotic in a hospital setting because you might be dinged by pharmacy and some other regulations because it's kind of off-label use of a drug. Yeah. But liquid embolics like Lipido emulsions do work really well, and they do cause less sort of off-target embolization. Specifically, mostly the main ones, are kind of skin reactions. Obviously, if that are very common with particles.
So what are the questions? So I would imagine if you have PAD and you're going to the ortho or you're going to an IR and you're checking into this type of procedure, a patient with PAD should be forthcoming. And if they don't know that they have PAD, they haven't been diagnosed, but yet they have high risk factors, high cholesterol, high blood pressure, diabetes, pre-diabetes, former smoker, chronic kidney disease, all the above, they should have their circulation checked, right? I would imagine get an ABI, get a leg artery ultrasound. But if you are going for something like this, you probably have already had some sort of CT angiogram or such, I would imagine. What are those tests?
What tests are you specifically talking about, Kym?
The test prior to GAE, or when you determine that you have arthritis in there, I would imagine that. I mean, I would hope the doctor wouldn't just go, "Oh, well, you probably have knee pain, you probably have arthritis. Okay, go away." There are probably tests there, but I don't know if those tests will show if you have poor general circulation to your feet. And I would imagine that especially if you're 1 in 10 over age 60 has PAD, I would think that most people in this bucket should get a vascular assessment prior to something like this?
Yeah, so that sounds like a two-part question to me, Kym.
Yes.
How do you look for PAD? How do you look for osteoarthritis? Or how do you determine who's a good candidate with a test for GAE? So peripheral arterial disease, we don't have to waste too much time on that. You want to get an ABI on our ultrasound as appropriate. I mean, your physician, your vascular physician or your primary care physician should be able to decide if you have risk factors and symptoms, then you should be getting evaluated for peripheral arterial disease. But for GAE, to qualify a patient for GAE, typically, what we start with the basics: a good history, a good physical exam. I have an orthopedic surgeon who works with us now, and I've relearned how to examine a knee, how to examine a shoulder, stuff from medical school many decades ago, right? So I have relearned. I mean, there are ways you can almost definitely diagnose a meniscus tear or a ligament tear. So my orthopedic exam skills are now great, as is my team's, right? And then, of course, we get x-rays on everybody. That'll tell you what degree of arthritis they have. Now, there's some data saying that people who get an MRI with contrast, and the contrast is kind of taken up by the synovium, they tend to do better than those without that sort of synovial uptake on MRI. So an abnormal MRI can also help, but you can't do MRIs with contrast on everybody with knee arthritis. I mean, that would just overwhelm the system. So it just goes back to the basics: a good history, good physical exam, x-rays, and then decide whether offer the option of a GA to a patient and see if they want to take it.
So
yeah,
I'm going to backtrack a little bit to Kym, to your original question that you asked maybe half an hour ago, which is who are the good candidates and how you choose who are the candidates for this procedure. So the baseline is you have to have a diagnosis of osteoarthritis, and for more than 6 months, okay. And that is refractory to conservative medical management. Like I do genicular nerve block and genicular arterial embolization in my practice. So the very similar sort of qualification for purposes of who would be a candidate: people who failed conservative treatment, right? And then they could have gone and failed intra-articular injections. So they usually already come in with a diagnosis of osteoarthritis. Now, if they didn't have a recent knee x-rays, obviously that helps, just to update because they could be walking around with x-rays for few years back when they were already diagnosed. It's a chronic disease that people suffer for a long period of time, and and obviously deteriorates as the time progresses. So yes, you check basic things like feeling a pulse, right? I treat PAD as well as Sid does, and I look at the patient kind of as a big picture. But a lot of those patients already had ABIs. But if they didn't, if you feel the pulse, then essentially you kind of can rule out significant peripheral vascular disease. Now, if you have any risk factors or whatnot, you can do a simple ABI. You do not need to do any vascular imaging, as you were asking, to check if their blood vessels are patent or not.
Definitely not routine.
Yeah. Unless you screen them, and then that points you to more severe vascular disease. And at that point in time, you're going into two different sort of pathway of workup and what takes precedence.
Yeah, I mean, just thinking outside the box, right, Misha? I mean, for instance, I have a vascular medicine doctor, I have NPs, PAs, and every one of them knows how to put a hockey stick probe on the dorsalis pedis artery and on the posterior tibial artery, and they can tell me whether they have color flow with polyphasic signals or not. I have trained them, right? So there's your PAD check. So when they say that this patient needs a GAE, they already know what the vasculature is. And if they find that on their bedside exam with a simple ultrasound probe that's abnormal, they order a full duplex.
Sure. Now, I have a couple questions. Go ahead. We have some questions that are coming in. I wanted to jump over to Dr. Patel, though, because he and I experienced a patient that called into our Leg Saver hotline who had a genicular arterial embolization, and it was performed through an antegrade approach, meaning coming down from the groin. But in my experience with some of the more advanced doctors, they tend to come up pedal, that come up through the foot and do what's called a retrograde approach. I'm not sure which is preferred, but what I found with Dr. Patel, right, with this particular case and a couple other that I've experienced, that there seemed to be greater risks with access in the groin versus in the foot for some of these patients. What do you think?
Well, I think it's experience and operator comfort with whatever access. First, when it comes to access, and I'll let kind of Sid weigh in because I know he's the TBL has some TBL preference, but in reality is, if experience trumps everything with access. So people who are comfortable managing the access, they can access anywhere as long as they know what they're doing, right? So that's the bottom line now in terms of how to approach it. That's more of a debate. A lot of people have accesses integrate. I know us does integrate access, and I know a lot of sort of academia goes access in an integrate fashion. I know that some places and some OBL places do choose the TBL approach, and obviously Sid can weigh in terms of why. And I will tell you that the people who do approach it in an integrate fashion, vast majority of them are able to easily access via TBL approach. Just a matter of a choice of how to, right.
I think from the out.
Sorry. Go ahead.
I was just saying, from the outpatient point of view, where it's all about patient comfort and patient satisfaction, and I think you can use a 3 French or 4 French catheter with the antegrade access, but you're still holding pressure in their groin, which is uncomfortable. So, pedal approach is maybe a better option in an outpatient setting compared to inpatient. I don't know if that's the experience you guys have, or I know a lot of the docs who treat CLI, they're very comfortable going pedal, but the docs who don't treat, CLI or PAD, they prefer antegrade or up and over. So, like you said, it's a personal preference, but for patient safety point, I think maybe pedal approach may be a better and safer route for outpatient purpose.
Yeah, I agree with Misha. I think it depends on your competence and your comfort level. But across the world, when you look at groin complications, irrespective of your experience and your expertise, there's about a 5% chance that you will have a bleed, a groin complication. Now, at our place, since we already know that they have good arteries going in, we go in through the foot. I mean, we don't even prep the groin. So for instance, a lot of these patients are older, they are higher bleeding risk. Like for instance, I'm affiliated with one of the bariatric surgery programs here. These are patients who have BMIs of 40, 50. I did one patient with a BMI of 61 recently. There is no way you can go through that groin safely. I mean, we finished it in under 35 minutes. That
definitely gives you a green light to go pedal. But if you choose to do so, but not not everyone is a BMI of 50 or 60. So,
Absolutely, and that's why I think it goes back to what you said, which is experience and expertise. And a lot of people still do it through the groin, and it's our personal preference because we have protocols in place that we just go through the foot almost in everybody.
I mean, it's just like with a heart cath, you still have doctors that prefer going through the groin and coming up versus going in through the wrist. So we do have Justin Lesh with Patient Pro Marketing. He's actually he's watching through our stream, our live stream on LinkedIn. And he brings up a really good point. There are a lot of patients out there, and we're featuring one of our patients that I'm really excited for everybody to hear his story, Jose, next Saturday on the Heart of Innovation right here on our YouTube channel as well. So make sure you subscribe. But he was 600 pounds. He had leg pain. He ended up with peripheral vascular disease. So he had arteries, he had veins. Then he had knee issues. So he had arthritis in his knees. And doctors were like, well, we can't do anything. You just need to lose the weight. And so Justin's bringing up the point that he does get a lot of primary doctors who tell the patients, if your knee hurts, go lose weight. And then this vicious cycle continues. What is your stance, on that type of situation with these patients? I know, again, it
So,
probably
yeah.
depends on the presentation of disease, the individual story, but just in general,
Are you
what's been
asking
your
me? Are
experience?
you asking me, Kym?
I will hear from all of you, would be great, but we'll start with you, Dr. Rao.
Sure. So again, this is why I think PAD practitioners are well suited to perform GAE, because you can clear the path to your genicular arteries by treating the PAD. So often patients that have, good genicular artery targets, I will, in the same sitting, treat their PAD also. Yeah, the presence of PAD alone is not a contraindication. I think you can treat the PAD and the knee at the same time. We do it often in the same sitting.
But what if someone has, for example, if someone is overweight and the primary care says, well, you need to suffer with your knee pain, just go lose weight and come back when you are thin and fit and
Get a
athletic.
second opinion.
So I think that, like the issue of weight is a big issue when it comes to
Literally.
BMI and and candidacy for knee replacement, right? So people get denied a knee replacement because they're overweight, because we know from literature that the complications of knee replacement in patients with high BMI is very high, and many surgeons choose not to do that because they understand that their rate of complications will go up. So one of the big recommendations is weight loss, right? And so they're kind of in this closed circle of like, okay, they can't lose weight because they can't walk as much because their knees hurting them, but they can't get a treatment to take care of what prevents them from walking in the first place to lose weight, right? So that's kind of a difficult catch-22 to be at for a patient. And personally, I think that for people who need to be bridged, there are some options. GAE is definitely a good option. It has probably, based on some early evidence and early literature, probably a best long-term or impact in terms of how long does it work. Actually, its efficacy for some of the literature shows up to 2 years for some of those patients, lasting effect of efficacy of GAE. And many of the other options, including intraarticular injections, are just don't work for such a long period of time, right? So with that said, there's another option, the genicular nerve block and ablation, that sometimes I will offer patients. It has a little bit longer lasting impact, but it may be much more temporary than GAE. That could be a good choice in that type of scenario, where all they're trying to do is maybe increase their the level of activity and possibly lose weight for next let's say 4 to 6 months, and that certainly will provide them that relief.
And so I want to jump to, we have Douglas in our live studio audience. He is the head of our PAD Warrior Task Force, our patient task force through the Global PAD Association. And he has a question that he would like to ask. And then I'll get to a couple from Sherry online. And then we'll go into our final questions of the day. Go ahead, Douglas.
Totally excellent show. The information is incredible, what I've heard today. Now, I live in the country. And how hard is it for y'all to get that information out there to those doctors? If I walked into my doctor Monday morning and said, what about this procedure? And he goes, I've never even heard of it. Because how hard has it been for y'all to get that information out there, other than the big cities, to those small town doctors that need this type of information? And I was going to tell you, Dr. Rao, if you want your CDL, holler at me. I'll help you get
it. That's funny, Douglas. Yeah. I mean, it's definitely a little bit of a challenge getting information out, but this is something that you do every day. I mean, every month, I think I meet at least about 3 or 4 physicians. I go shake hands with them, and they've never heard of this. They don't even know that it's an option. So there is no easy fix for this, Doug, but people like me who are passionate about this new field, I think they have to put windshield miles on. They gotta go out and meet people and educate. Educating patients and educating physicians, I think, is they're both important.
I agree. Dr. Ginsberg?
Yeah, I mean, at the same time, we have to be sort of careful. We're early in terms of the data, right? Like it's, we have some data, but it's still not in the guidelines. It takes longer time to get incorporated into the guidelines. So, yes, it's an option that works for some people. We still don't, there's a lot of questions that have not been answered when it comes to this procedure. And so, it's not something that people can sort of introduce and say, hey, this is when you fit into this algorithm and you're a good candidate for genicular arterial embolization, right? Like some of the procedures Kym mentioned before, we talked about prostate artery embolization. That's an embolization procedure that's clearly in the guidelines, and there's many of those. And then there's still literature, still evidence, still research trials that need to show that this is definitively works for patients and is safe. Okay, also, right, which is critical because we want to make sure that we provide a procedure that works, but is also extremely safe for our patients. So once those things are clearly proven in sort of randomized control studies, then it should be incorporated as an option into the guidelines. And I think then at that point in time, then that would be a kind of a knowledge that would be expected from general practitioners, right? Because that's within the guidelines. Currently, it's more of an. Go ahead, Sid.
So one thing though, Misha, CMS has approved this as a procedure for Medicare beneficiaries, right? Anytime somebody is not a candidate for knee replacement, CMS says it's absolutely fine to do this if they are not candidates for surgery. So there is, yes, it's not in the orthopedic surgery guidelines or it's not in the IR guidelines yet. But the way to get to guidelines is through data, like you said, through clinical trials, through registries, to publications. And so I don't think it's wrong to go and talk to physicians about what's already out there and say, hey, look.
No, I'm not saying. Yeah. I'm not, definitely not wrong. I'm not criticizing you in any fashion. I think it's. I mean, you're educating, people who. Essentially the same story I told Kym before. Like one of the digital marketing people talk about this procedure with patients. The first place many of those patients end up going to is their primary care doctors, because it's for many people listening about GAE can be a little bit mind-boggling. What are you doing again? You're going through the blood vessels to treat my arthritis? How does it even make sense, right? And so, a lot of people are skeptical, and I was also, 5 years ago, I was skeptical about something that's working through the blood vessels, taking care of osteoarthritis pain, right? So, so then, eventually that information gets there, but we certainly need more evidence to continue building that evidence to support this procedure, and so working through primary care, that's a good way to promote this and discuss this as an option, explaining to them, I think that, which is important, and again to reemphasize that this is not a competitive procedure to knee replacement, right? Knee replacement is still the gold standard. And this is an option that could work for some patients.
Yeah, nor is it a silver bullet. Nor does it work in everybody. And that's one thing I educate my primary care physicians to saying, hey, I'm not saying this works for everybody, nor is it appropriate for everybody. And that's where the clinical skill kind of comes in patient selection.
But here's the thing is, and I just had this discussion on my LinkedIn page with a post by Dr. Miguel Montero Baker, vascular surgeon, as well as Dr. Michael Lichtenberg out of Germany, where, a lot of doctors are still using plain old balloon for angioplasty and not accepting any other innovative approaches that might improve outcomes. And the biggest thing that they're saying is, well, there's not enough evidence. Well, I'm not trying to be insulting, but my understanding is that medicine is a practice, right? And you need to practice medicine to create the evidence. And those that are going to you and saying, well, there's not enough evidence, so I'm not going to do it. Why aren't these doctors literally engaging in trying to create the evidence? Because I'm going to tell you, these patients are suffering. There are millions and millions of people across the globe that are suffering with chronic pain. And especially over in the UK, I have patients that are waiting years for knee replacements, for hip replacements, and they're doing absolutely nothing but pushing pills. What if for those, years that they have to wait for a full knee replacement, why couldn't they offer something like this instead of opioids or some other pain medication to actually help remove the suffering during that time?
Well, I mean, I think England is one of those places actually where they doing some amazing trials. Genesis trial with knee osteoarthritis by Dr. Little. I think that they already kind of showed 2-year outcomes for genicular arterial embolization. They're doing Genesis 2. I think that Britain is way ahead of its game in terms of getting it to the guidelines. Right? They're doing the work. It just takes time. This is an innovative treatment. It certainly hits right at the spot where there's a big gap of treatment, right? Like essentially a lot of people are suffering high incidence, as Sid mentioned, high prevalence, and not a lot of good solutions. And people are sort of rushing to get something that now works or potentially works, and have been kind of denied a lot of other treatments. So what we sometimes, we start doing as doctors who like being a devil's advocate here, who perform procedures, we sometimes kind of start treating patients before evidence matures, sometimes seeing some results, but and that's kind of a fault of a lot of people who do procedures. They start doing things, but ultimately sometimes we are proven wrong. Maybe it's placebo. Placebo has a lot to do with a lot of procedures. So it's very important to kind of go based on, yes, now we have more evidence to support this procedure and the fact that it works. But ultimately we need something that to definitively put it within the guidelines to feel very comfortable with performing these procedures. Sid, I just
yeah, and usually by the time the guidelines come out, they're old. Usually guidelines come out and then they're well behind where the evidence actually is, which is just chicken or the egg. I mean, you're constantly chasing your tail here when it comes to guidelines. So that's, just frustrating. But I do have just a couple questions coming in from Sherry. I don't want to take up your entire Saturday afternoon here. She is really curious in her situation, but is there a difference between psoriatic arthritis and osteoarthritis? She has psoriatic arthritis and wonders if this might be an option for her. She was told years ago needed knee replacement, then said, just use a walking pad, go ahead and just try and keep walking as long as you can. But her knees, she says, really hurt. She had 3 right knee surgeries before, but they said the left leg is worse with arthritis now than before. So she's wondering who she can see and if you think this might be an option for her. I know it's tough to tell, you don't have her medical reports, but just in general.
So this hasn't been studied adequately in psoriatic arthritis, Kym. To recommend this as an option is, I think, pushing the limits of what we should be doing. So, Misha, have you ever treated anybody with psoriatic arthritis with this?
And what's the difference between the two?
Yeah, so
I haven't. Go ahead. Go ahead, Sid.
Yeah, so at a cellular level, Kym, all these arthritis are very different. The type of cells that invade the synovium, the bone, the cartilage, they're all different. The mechanisms inflammation is a very broad term here. When you say psoriatic arthritis or osteoarthritis or rheumatoid arthritis, but they're actually at the cellular level mediated through different mechanisms. And that may explain why, it works better for osteoarthritis than it for, there was some preliminary data that Dr. Padia and these guys looked at for rheumatoid arthritis, GA and rheumatoid arthritis, but it's not very effective in these kind of so-called inflammatory arthritis. So So to answer Sherry's question, there is no great data to say that this will work for her.
I think that people are starting to
okay,
say,
so my final question.
I'm just gonna quickly jump into that. For we mentioned inflammatory and non-inflammatory osteoarthritis, right? So remember, we have nothing in our hands to slow down osteoarthritis. We do not have any disease-modifying agents. Inflammatory arthritis, we have those rheumatologists have disease-modifying agents to cut down on autoimmune arteritis, right? So there's other treatments that are effective potentially that would stop the inflammation in an autoimmune arthritis like psoriatic arthritis or rheumatoid arthritis that can be incorporated, right? We do not have such an agent for osteoarthritis.
Correct.
So it's a different thing. So I think that before you jump into the inflammatory osteoarthritis, we need to check and ask, were those patients already treated with all the disease-modifying agents for like rheumatoid type of situation before we jump into some unproven methods of treating these conditions.
Correct.
And I think in the future, I think, Doctor, I might be flying back to North Carolina. Might be one of the few first for my hand after I ended up after the COVID vaccine. I ended up ANA positive, joint leakage, osteoarthritis. I mean, fun stuff, and it's settled, thankfully, right in my hand, my right hand of all things. And so we're going to be working on possibly giving me some much needed relief there. And then we can come back on and talk about this even more. And I'll be able to share from personal experience what the relief is.
We're getting ready to publish our 6-month data on hand osteoarthritis treatment, Kym.
Really?
Yep. So far, very promising results, about 85% efficacy or so.
Do you treat it with angiography or just under ultrasound?
Oh, with angiography. No, I'm not. Dr. Okuno can do a lot of things we can't do here.
No, I mean, you can do it here too. I mean, it's like realistically speaking, but Dr. Okuno does do those procedures without angiography for small joints interventions.
Yeah, okay. I do them with angiography.
Do you access radial artery or do you?
Correct.
Do you do?
Antegrade radial.
Okay, so straight down.
Yeah.
Interesting. So it should be pretty quick and easy, in and out.
Yeah, about
1 hour.
10-15 minutes. I just put the dilator of a micropuncture sheath, so the arterial puncture is even smaller than the IV that you get.
So I can get back to creating more inflammation and damaging my hand by holding my phone for 24 hours a day and typing.
Absolutely, Kym.
Right away.
Right away.
So my final questions of the day, these ones are really fun. You can take them wherever you'd like. They're pretty open. We have our first one, which is the journey to diagnosis. This relates more to peripheral artery disease because it's such an issue when it comes to the diagnosis. There are so many misdiagnoses of peripheral artery disease. And so what we like to do is we like to have you share a case where even today, this case still comes to mind because you can't believe that doctors did not catch or diagnose this patient sooner rather than later. They may have diagnosed it with back issues and performed a spinal fusion. They may have performed a hip surgery when it was really their iliac arteries that were causing a problem. You get where I'm going with this, but is there a case that stands out that would serve as a lesson for patients out there that if you have these symptoms and the doctor says X, you still might want to get that leg artery ultrasound just in case? We'll start with you, Dr. Rao.
So I think, PAD is a great mimicker. I've had patients with who were diagnosed by their primary care physicians and their endocrine physicians to have neuropathy, and they suffered with color change and pain in one leg rather than both legs for many, many, many years before somehow they found their way to me. And I did a good clinical exam and then an ultrasound, and I found that their popliteal artery was blocked. So again, what I tell patients is, hey, look, if it doesn't make sense, if you aren't getting relief, think differently, ask for a second opinion. So yeah, I mean, I still remember this patient whose popliteal artery I opened up. She had pain, I think, for almost about 7 or 8 years, chronic, intermittent pain, worse at night. So everybody thought it was just neuropathy, but neuropathy rarely affects only one leg, right? It tends to be a little bit more bilateral. So when I saw that she had pain only in one leg, then we did the workup and revascularized. I mean, she's been pain free now for a few years after one revascularization. So it makes a difference in her life. That's the patient I can remember about PAD.
What about you, Dr. Ginsburg?
I mean, I think that a lot. They're definitely a mimicker. I would agree with completely with Sid. I think that a lot of people tend to sort of deny their symptoms. That you need to really dig deep, and then you realize, oh yeah, well, they actually do have what we call rest symptoms, right? They just don't recognize them as such. They just learn to live with that, right? Like they sometimes dangle their foot, because it gets numb and painful, and they don't think it's abnormal. They just think it's part of whatever, and they could be living for years with those issues. Sometimes, eventually, I kind of explain to people, like when they already present with something, what we are seeing is just, the 10% of the iceberg above the surface. The extent of their peripheral vascular disease is the 90% that we do not see. No one sees until we start looking into it, and their disease is so much more severe, right? Because a lot of times it can be silent, and then when it already sort of surfaces, not just with that, but more of like a critical limb-threatening ischemia and wounds that don't heal, that's because a lot of those people essentially ignore their symptoms because it was slowly evolving symptoms that they kind of thought, okay, they just change, they stop walking as much, they walk less, maybe they come and try to find that parking spot right by the store instead of walking for a longer distance. Maybe they'll when they shop, maybe just a limited thing. Everything kind of changes, and it's crippling over time to the point where they don't want to walk at all, right? Or minimal. Yep. And so to me, it's always mind-boggling how people could be living with symptoms that are very slowly, gradually getting worse, but and completely change their lifestyle. But their mindset is just because it's such a slow changes. It's it's age related or whatever it is. And so once you start uncovering it, you're like, okay, well, you have all the symptoms plus some, and nothing has been done so far until you have this. It can be quite shocking.
Yep.
Yeah,
pain is not a normal part of aging.
No. And that's my favorite thing is when my patients sometimes will say, oh, I don't have any pain. I don't have anything going on. But when you dig into it and you're like, well, what were you doing 3 months ago? Oh, you were walking 2 miles 3 months ago. Well, how far are you walking now? Well, I mean, I just walk to the driveway and get my mail stuff and back. I mean, because it's really hard. I just can't make those 2 miles anymore. Well, why can't you you have to keep digging and digging and digging and digging. And then they finally go, oh, yeah. Well, yeah, I was in pain. That's why I stopped doing it. But I'm not in pain anymore.
Exactly.
Because you're doing absolutely nothing.
Yeah.
And so that's the problem. So when people are saying that these patients, are, well, they're asymptomatic, so there's no problem. Well, they're not really asymptomatic. And they're saying they're asymptomatic to the point where they result where they're a toe step away from amputation, right? Where they have a wound that won't heal. But they did have these signs leading up until, and they just ignored them. Okay, number 2, the pulse, which is share a case in which you learned the greatest lesson that others can learn from. I don't care what case, it could be PAD, it could be GAE, but share a case, but recognize that it's just what you're saying is going to be all inclusive, that there's going to be no preface or anything. It's just going to be you sharing this case that you learned from. So it's going to be mainly geared towards physicians. So it's what they can learn from. but patients will also just be tuning in, so keep that in mind. So share a case in which you learned something critical from that you think others can learn from, and it could be a success, failure, doesn't matter.
Wow. Okay. So for those of us who treat patients with wounds, Kym, I think every case is a learning opportunity. I really do. I mean, I've now done thousands and thousands of interventions. I still feel like I learn something every day. I think the biggest sort of message that I have for people who are in this field, um, and for patients who've had a procedure at one institution, is just because somebody failed to revascularize you doesn't mean a second person can't. And it kind of goes back to your recurring theme of get a second opinion. I've seen reports from very esteemed colleagues in the area saying, there's nothing more I could do. But these patients come to you and say, I really don't want to lose my leg. So you put them back on the table and then you say, I think I see a little channel there, or I think I can use my wire and this catheter that I have to open up those blockages. So I think till you have personally tried, you can never give up easily on these patients. That's sort of the general message that I kind of have about this question to yours.
Yeah, no, I agree. I had a doctor and I was so upset recently, and he said, oh, well, this patient, he has a really good doctor. So, I mean, they've had this many revascularizations in the past 6 months. So I just don't think it's appropriate for me to do another one. Well, what if that doctor you think might be good might not have that extra little finesse that you do and you don't realize it? What if just that one procedure that you do could have replaced all 6 of the ones the other person did? And it might be durable. It might just be that chance that that you're willing to take on this patient that could save the limb. Just like we had last night with a doctor who called me and he said, Kym, I have done, this is the patient's 5th angio. It keeps closing up. He keeps clotting, like literally we close him up and he clots. And then he's lost a toe. I don't have deep vein arterialization as an option yet, where they hijack the vein into the and go into the foot through the vein. Do you know someone? And it was so amazing that he got on the phone with one of the doctors that we introduced him to, and within an hour, the patient was in an ambulance on their way to the other facility. And I just got the message that he's being worked on right now. That is incredible. And it's especially credible when a doctor in particular knows that there are other options that they may not have, and becomes the hero because they give up the patient versus giving up on the patient, right?
Good point.
Dr. Ginsberg.
No, I mean, I agree completely with Sid. I think that, I
How about
personally,
sharing a case though?
Yeah, no, I will, but I think that in terms of sending the patient, a lot of times I tell people, this is, something that I recommend to them, to go out there and seek for a second opinion. Sometimes, when especially when things are a little bit more questionable. Not there's no like definitive answer. We can try this, we can try something else, but I don't know for sure if it's going to work or not. And I think that those are exactly the type of cases where it's nice for them to go out and seek another expert opinion that may change the course, may not change the course, but at least we haven't decided to do something that may have been not the right choice for them. I think that in terms of patients, and when you guys kind of mentioning the whole pathway of critical and threatening ischemia, ultimately a lot of it also ends up being in those very difficult patients on shared decision making, because there's also sometimes how many times you try, right? Like, and I agree with you completely that there is options out there, and they should also always, you should always ask them to go and seek out. And I think that, Kym, you're doing an amazing job in terms of providing those people with options like DVA which is not something that majority, I would say, of people who take care of peripheral arterial disease patients perform, right? Just because it's it's a slightly different approach, but for people who have experience and obviously at risk of potential limb loss, and that's the last option, that's certainly something to explore. So in terms of the case, I don't have a good case where I can tell you and answer your question the same way. I think that sort of Sid mentioned.
I can ask you a better question.
But I think
then.
sure. But I think that every like mentioned before, every patient is a learning opportunity too. Like I'm not, it's just you learn at something every day. You improve incrementally every day, and you're better off next time you're taking care of your patient. And so stay humble and realize that this like we're talking about right now, things that like musculoskeletal embolization that I could not have imagined 5 years ago that we would be pursuing and doing, and now we're learning a completely new field that's exploding. So so you have to stay humble and continue learning.
The final two questions, and I'll let you know the first one so you have time to think about it, and then we'll it's the 6 minutes that matter. It's the moment, the real inflection point in your career that brought you to where you are today or led you in a specific direction. It could have been a conversation you had. It could have been a patient you encountered. It could have been a specific case. It could have been something you watched on TV, a milestone in your life. What were the 6 minutes that mattered? What was the catalyst for some major change in your life that was a defining moment for you?
Defining moment as in what led us into this field, or maybe
you can take it. You can take it anywhere you want. I had Dr. Mahmoud Rezaveh, a top interventional radiologist out of Southern California. He said what his defining moment in his career is when the moment his mentor said, if the contrast fluid can get through, so can you. We've had Dr. Lichtenberg out of Germany who said that he decided to follow his heart in angiology after the birth of his first child, when his wife said to him, hey, you don't want to bring your child up in a home where you're not happy with your career. Follow your dream and lead by example. And that's when he moved into angiology.
Yeah, for me, I think moving from the hospital system to the outpatient lab was a huge sort of change in my career because now you are also a business owner. You're trying to take care of your employees, so you're wearing multiple hats. It was not an easy change, but when I saw that I could potentially take care of people better with less red tape. I think the straw that broke my back, so to speak, was when I had to ask for a new interventional wire at the hospital, and I had to go to a committee that had 4 other doctors, none of whom were vascular physicians. I had to speak with an OBGYN, a neurologist, a thoracic surgeon, and a pediatric surgeon about why I needed a new interventional wire. And I said, I don't think I'm ever going to be at the cutting edge of anything if I have to face such kind of red tape. So that was a sort of an aha moment for me, and said, hey, you're at the prime of your career. You probably need to do this on your own. And I've never been happier, Kym. I can move. We now have the only practice in the area that can see any patient within one business day. Nobody can offer that here. And I'm so happy that I can do that now. So that was my aha moment, I think, when I went in front of that committee that wanted approval by 4 non-vascular physicians to approve a vascular device.
Nice one. That's a really good. I'm sure Misha could relate to that. But Dr. Ginsberg, what was the defining moment for you?
So essentially, we talk about happy wife, happy life, right? So this is the opposite. Okay. Now interventional radiology is a residency, so people just go directly and they know they want to go and do this and take care of patients essentially, as opposed to being in front of a screen and do a diagnostic radiology and maybe do some IR and choose it later. So when I was doing my training, that was not the case. We did the residency in radiology, and then we subsequently went for fellowship to train in interventional radiology. So while you may have been inspired initially to go to, let's say, one field or do IR, for me it was IR that sort of kind of drew me into the field. In the process of training, you may see some other things and may be swayed to go to a different specialty within radiology. So when it came time to pick the specialty or subspecialty within that field, I had my sort of debate in terms of what I should do, and my wife had no debate. Okay, she had no doubts. She said, "You have to do IR," and I'm like, "Why? What do you know?" I'm like, "I've been there. I've been doing my, essentially my rotations. I've been working. I've been seeing it firsthand. How do you know what I have to do?" So, and she says, "Well, I see you every night. While you have the longest days doing IR, when you're doing your rotation IR, you also come back the happiest, right? So the lesson is, do what makes you happy, and you'll never work another day in your lifetime, right?" So I followed the advice of my wife, and I did what she thought was making me happy, and I'm happy to this day.
I love
Thanks
that.
to my wife.
That's such a beautiful story. For my final question, going back to GAE, because I think that it's really important. Please relate it, because it's going to be encapsulated into your own little segment. I have nothing to do with it. You're the star of the show. But we have a series called Go with the Flow, and it's tips and tricks on walking as medicine for patients with peripheral artery disease. And I would think that you both can step on each other's toes and repeat it, because they're going to be two different segments and just two different voices on it. But I would love to hear your best advice for patients with PAD. They're struggling with walking, and oh my goodness, they might have plantar fasciitis. Oh my goodness, they might have osteoarthritis in their knee. What is your best advice for these patients?
Don't take no for an answer. Get a second opinion. That's the simplest advice I can give patients. Medicine changes every day, Kym, and there might be something that your trusted physician, even if they have the best intentions, might not know of on the horizon. And I think it's important for patients to be their own best advocates and say, is there something else that can be done to relieve my pain and suffering? So if you have PAD and if you have a knee that hurts, get a second opinion from somebody who can treat both.
And Dr. Ginsberg, do you want to be a little specific on the GAE and for people with PAD, and the potential also for the option of it nowadays for plantar fasciitis as well?
I really like, Kym, your emphasis lately, on walking, right? And the fact that, staying active, right? And I think that both of them are actually important, both in the world of PAD as well as in the world of osteoarthritis, right? So we want people to stay active as much as possible. We want to keep them in the game. And so if, it's actually been shown to improve both arthritis and PAD, right? So, walking or moving and choosing a sedentary lifestyle is critical. Okay, and and if you're talking about PAD, at different stages, the best treatment is prevention, right? And risk factor modification and lifestyle modification, right? And those things are critical, right? So instead of kind of treating it at the end of the disease, staying active, being in the best shape you can be, can prevent disease, as opposed to looking for when you already have the disease. Yes, we have people like Sid who take care of the patients, and I'm here to help. But my hope is is that people stay active and prevent disease from happening in the first place.
Thank you both so much. You have been such great sports. You've spent so much of your Saturday with us here. We appreciate you. We hope we have both of you back. Again, if anyone watching has any questions about at the genicular arterial embolization, or you have questions about PAD, just give us a call at the Leg Saver hotline at 1-833-PAD-LEGS. That's 1-833-PAD-LEGS. We will get with Patient Pro Marketing and find a great doctor who performs GAE near you, if that's your interest, but also for PAD. We at the Global PAD Association can help you find a doctor who is skilled in advanced limb salvage as well. We just don't want you to suffer. We want to get you back up on your feet and walking. Thanks so much, everyone, for joining us. Thank you. Make sure to like this video and subscribe to our channel for more great content such as this.
Thank you.